Good afternoon, everyone. I hope everybody has come fresh after a small evening nap. So we'll start with the management of squint. We are not going to, the scope of the presentation is for general ophthalmologists, for residents and other people practicing other subspecialties in ophthalmology, for them to gain and also refresh the knowledge on how basic squint in children is tackled. Good afternoon, everyone. I hope everybody has come fresh after a small evening nap. So we'll start with the management of squint. And we'll share some surgical videos on the common surgical procedures that we do. So this session, we are going to cover esotropia, exotropia, pattern deviations, DVDs, and we'll also have a look into how adjustable switches are handled. So coming to esotropia, which is most commonly seen. So we'll talk about non-surgical treatment and also the surgical treatment. So the non-surgical treatment is only available for refractive accommodative ET and non-refractive accommodative ET. So surgical treatment is the treatment of choice for non-accommodative esotropia, which is what we commonly see in practice, which is also commonly referred to as infantile esotropia or congenital esotropia. So now we'll come to accommodative esotropia. Since we are all fresh now, we'll first deal with the difficult topics first. And as we go, we'll see more of videos. So accommodative esotropia is a esotropia which reduces with glasses, to put it very, very simply. So why esotropia is caused? So there is an uncorrected refractive error, like uncorrected hyperopia, which causes blurring of vision. So when the child sees a blurred vision, so they automatically accommodate to get more clarity. So along with accommodation, we have convergence also. So the eye goes for convergence. And these patients, usually the fusional divergence is weak or insufficient to hold the eye straight. So this is the mechanism by which the esotropia is produced in when there is an accommodative component. So first we'll deal with refractive accommodative esotropia. So there are two types, refractive accommodative and non-refractive accommodative esotropia. So we'll just give some clinical scenarios, and from that we'll see how these patients are being tackled effectively. So the first scenario is a 3-year-old child who presents with esotropia. Extraocular movements are full. On cycloplegic refraction, we have a plus 3.50 diopter of hyperopia. So when you look into the prisms, when we measure the ET without the glasses, it's coming for distance 35 prisms and near esotropia of 30 prism diopters. So now we'll see what happens when we give these glasses. You will see that there is a drastic reduction in the size of the esotropia. It becomes a phoria. So E indicates phoria and capital E with a T indicates esotropia, which is a manifest squint. So now we'll give the glasses and we'll see that the child is straight without. This is a child with glasses after giving a correction, and you see how straight the eye is. So this is very simple. Child comes with esotropia, you do cycloplegic refraction, you have a hyperopic correction. So then you give the glasses, the eye becomes straight. This is a small video just showing how we show it live as to how the correction happens. So the child is having an esotropia for near. So with the glasses, you see it's almost straight and there is no any gross manifested ET. So this is a very typical case of a refractive hyperopic refractive accommodative esotropia. So now we have given glasses. Let's see, like usually the hyperopic refractive error keeps increasing up to the age of 5 to 7 years. So after 5 to 7 years, we need to think about weaning the patient from the glasses. So this is a case where patient is already wearing glasses, patient with refractive accommodative esotropia, wearing glasses, 5-year-old child, vision 6/9 in both eyes, and with the prescription which the child is wearing for distance and near, there is ortho. So when the child comes to you, what do? So you reduce the correction and see. So you might reduce 0.5 or you might reduce +1 and see how the ESO behaves. As you see here, there is a slight increase in the ESO. It has manifested as a phoria, 4 prisms for distance and 6 prisms for near. If you further reduce the glasses, the phoria will increase and become a tropia. So with this correction, when you see that it has become phoria and the vision is also good, then you reduce the glasses and give it to the patient. So this is how we wean the glasses in case of a refractive accommodative esotropia. So now we'll come to the second entity, which is non-refractive accommodative esotropia. So here also we will see a case scenario. So 5-year-old child with esotropia presents, then you do a cycloplegic refraction, it comes to around +3.50 diopters. So without the glasses, you see there is a distance ET of 25 and a near ET of 50 prisms. From this itself, there is a discrepancy between the distance and near. So now you give the +3.50 diopter, which you have found out through your cycloplegic refraction, and see how the esotropia behaves. So you'll see that there is a drastic reduction in the distance esotropia, but near it is reduced from 50 to 25, but not significantly. So if there is going to be a correction and then you see a distance near disparity, you have to immediately look for AC/A ratio. It's not very complicated. You just see the correction with the near ET and then you have to put a +3 diopter add and see the deviation for near. You see that the deviation for near with the +3 add has reduced 3. So now you put this 25 prisms and distance deviation for near with +3 diopter, which is 3 prisms, and the near add, which we have used as 3. So it's coming to 7, which is high. So AC/A ratio usually from 3 to 5 is normal. So anything more than 5 we considered as abnormal. So since with +3 add we are getting a very small esophoria only, we'll give the distant correction as +3.5 diopter, which we found out with cycloplegia, and then the near add of +3 diopter, whereby the child will look straight with the bifocal add. So this is a deviation for near for distance. So using the targets in the upper segment, we are seeing the for near. So for near there is esotropia, but with the add glasses, it's almost straight. So the demonstration of near deviation with target in front of the patient. So you see that with the bifocal add, the patient is almost straight. So after you give the bifocal, then what next? So you have to wean the glasses. So as I told before, around 7 to 5 years, then you start weaning the glasses. So you have a clinical scenario where the patient, 7-year-old with the hyperopic correction with the bifocal add is coming. So this is how the ET is looking like. Only with the distant add of +2, the distant correction is 4 and the near is 24 prisms. And with the bifocal, both the distance are almost correct at 4 prisms. So now this is what the child is wearing. So now the child is coming for follow-up. What do you do next? So you keep assuming that the hyperopia for distance is remaining same. You just start reducing the add. So since it is 2.5, now you reduce it by 0.5 and see how the esotropia behaves. So now with +2 add, it is only 8 prisms esophoria. But if you reduce it further to 1.5, then it becomes 12 prisms and it becomes a intermittent ET. So you don't want any manifested squint. So you are happy with this phoria itself, and so you prescribe the initial 2.0 diopter hyperopia and the reduced +2 diopter of hyperopia. So this is how we wean the glasses for bifocal add for a non-refractive accommodative esotropia. So decision making, so child comes with esotropia, you do cycloplegic refraction, patient has a hyperopic error, you give the full correction and see what next. So there is no esotropia for distance and near, it is a refractive accommodative esotropia, so you give hyperopic glasses. But there is no esotropia for distance, but for near it is present. So you immediately you have to do the AC by A ratio, and if it becomes less, then you give a bifocal add. So this is how the two accommodative esotropias are managed. It's quite simple, and we have also dealt with how we wean the glasses over a period of time. So some children, very rarely, they come out of the glasses completely, but usually it is not. So some amount of correction and add they will keep wearing for life. So then there is an entity called partially accommodative esotropia. So there is reduction of esotropia with glasses, but still there is some residual esotropia. So as you see in this patient, you have a cycloplegic refraction of +3 diopter. Without correction, there is distance 30 and near 35 ET. And with correction, there is distant EC of 20 and near ET of 25. You see that even though there is a reduction in ET, it is not completely cured. So some residual ET is also there after the full correction of the refractive error. So in these cases, you have to think about surgical management for the residual ET. So with that, we come to an end with regard to management of accommodative esotropia. So what surgery we'll do, we'll see as we go. So the next common entity is infantile esotropia, which is very commonly seen in our part of the country. Accommodative components are very commonly seen in the Western population. So in the Eastern population, we among the esotropias, almost 85% of the esotropias are because of congenital ET. So we know about the typical presentations, very large angle ET associated with oblique overactions and dissociated vertical deviations. And these differential diagnoses, we have to definitely keep into consideration and rule out before we decide on surgical options. So what are the surgical options available? So there are two options. Either you do a resect procedure where you recess the medial rectus and resect the lateral rectus, or you can go and do both medial rectus resection in both eyes, which is bimedial recession. So practically, when you deal with patients, especially parents, they usually don't prefer to get both eyes operated at one go. So we commonly perform resect procedures. And timing of surgery, this is very, very important. I want everybody to show some attention. Like we operate as early as 1 to 1.5 years, especially the first eye. Because by the time the patient presents, it becomes around like 6 months. Minimum by 6 months only they present. So after that, you institute amblyopia therapy by patching, and then you ask the patient to come for 1 or 2 reviews. By the time it becomes 1 year. So the first surgery is done between 1 to 1.5 years. And the second eye, if there is any residual ET, which is very significant after the first surgery. We'll do it after 6 months. So now we'll just go into what is the basic surgeries. Recession and resections are the very, very basic surgeries. We'll just dwell into it. So recession is weakening of the muscle. So recess means a gap or a break, and recession is going down. So as you see, this is the attachment or the insertion of the muscle. So if you put the muscle behind, we call it as recession. So this is the original position and this is the insertion. So muscle is reinserted and reinserted posteriorly into the sclera by inducing a slack or a laxity. So we'll play this video on recession. So this is a medial rectus. It has been exposed. A second hook is being placed. Now we are putting the sutures. So we use the 60 vicryl suture with a spatulated needle. So the first bite is usually a superficial bite into the muscle. And the second bite includes the whole muscle. We go inside and take a whole bite and we secure the knots tightly. So one side of the muscle is secured like this. So we have to tightly secure it, and we have to make sure that there is no tenons in the area where we are putting the sutures, because it will slip off. So likewise, the other end of the muscle is also sutured, and we are disinserting the muscle. So we are disinserting it and we are placing it behind. So we are marking around 5 millimeters behind the insertion of the original muscle, and we are taking the scleral bite. So this needs to be done very carefully, otherwise you will have a perforation, which is one of the complications. So make sure that you do it very slowly and carefully. The other side, other end also, it is taken. And the sutures are tied. So that now the muscle has a new insertion site, which is behind. So this is the original insertion, and we are putting the muscle 5 millimeter behind the insertion. So that's it. We have secured the muscle. So after putting it, we need to cut the sutures off. So before cutting the sutures, we'll see whether everything is okay, whether the muscles are properly attached, whether there is any laxity. And then we'll go and remove the sutures. And then we'll retract the conjunctiva and we'll suture the conjunctiva. This is also absorbable suture. This is a 80 vicryl suture. So this is how a recession is being done. So this is a very, very basic procedure. So the type of anesthesia, usually for children, we use general anesthesia. But for adults, we prefer retrobulbar or peribulbar. Usually subtenons is not much preferred in squint, because once you give the subtenon injection, the all the subtenon space gets bulged and we find it very difficult to do the tissue dissection. So usually we prefer retrobulbar or a peribulbar block. Some people use topical using xylocaine jelly and IV sedation, which we usually don't do here in our institute. Then we come to the next most common type of muscle surgery, which is resection. So resection is basically to strengthen the muscle. So you either remove or cut the muscle. So as you see here, this is the original insertion, and here this part of the muscle is being cut and brought forward. So this is how the muscle is shortened and strengthened. So here also we'll go through. This is I would like to mention the incision. This is a limbal based incision. So this is how we make the incision. So first we make a incision towards the fornix, and then we dissect the tenons and cut it very flush with the limbus. As you see here, because it's a very young patient, the tenons is very much thick, and it's also very sticky. So you really have to be a bit patient. So now we are lifting the conjunctiva and dissecting the tenons away from the conjunctiva. Now we retract and then put a small side pocket so that it's just in front of the insertion of the muscle, edge of the insertion. So then we introduce the hook and hook the muscle. This is the resection that we are performing on the lateral rectus. So once we hook the muscle, we only hold the conjunctiva and try to remove all the tenons attached to it. You see how the tented the conjunctiva is. So you have to pull it up and then cut the tenons away from the conjunctiva, relieve the conjunctiva from the tenons, so that when you reoppose it, it comes out and then forms very easily. So these are the intermuscular attachments. As you see, we are almost in the process of exposing the muscle. So now we have removed all the tenons and the muscle is ready. So now we have to mark over the muscle. So this is resection. We are going to cut the muscle. So we have to mark it over the muscle, and you have to put the sutures in the place where you have marked over the muscle. So here also we follow the same principle. So we'll first make a partial thickness entry and come out through the marked area on one side of the muscle. And then the second bite will include the whole full thickness of the muscle. So once the two bites are taken, the muscle is secured. And the other side is also secured with the same bites. So now we cut the muscle from the insertion and try to bring forward, and because you are cutting it in the insertion, there will be bleeding, so you cauterize it, and then you take the bite at the insertion site. So whereby you are trying to bring the muscle forward. So the other side is also taken, and we pull the muscle to the front, and you see the redundant muscle in the front of the insertion. So that is what we are going to cut it off. And that is So now we'll cut the redundant muscle. So we'll check whether everything is properly secured, remove few adhesions, and then you remove the cut the sutures off. So a very simple procedure. So now we have to, since you have cut the muscle, there will be redundant conjunctiva also. So you make sure that you stretch the conjunctiva and then resect it also for proper effect. Otherwise, there will be bunching of the conjunctiva near the medial area. I mean, the area where you have left it like that. So it will lead to a lot of Dellen and tear film instability. So you have to cut the redundant conjunctiva, and finally you need to secure the wounds and try to check before you close the eye, because it's under general anesthesia, and these conjunctival sutures are very high chance of getting untied. So you need to really tie it and check it in the end before you close the eye. So the steps of resection: first you mark over the muscle. So suture is placed over the muscle. Muscle is cut from the insertion area, and sutures over the muscle are brought forward, and bites are taken in the insertion and tightened, and extra redundant muscle is cut off. So this is how the resection is done. And these are some of our post-op photos. You see on post-op day 1, a large angle squint, which is being corrected with the recess resect procedure. You see, though the correction has been done, it appears as though the child is having a squint. So this is what we call it as pseudo squint, because there is a very large nasal bridge. You see a very large nasal bridge, and we have the epicanthal folds. So this is, it appears like a pseudo squint, but actually the eye is straight with a good correction. So this is a relatively old child. It's a girl with alternating squint. We have done on the, mainly the surgery on the left eye, and we have also done some surgery in the right eye for the infraoblique. So that's why it is slightly red on that side. So here also we are able to get a good correction. This is 1 month post-op. So you see all the conjunctiva is well healed, and you don't see any scars. There is a noticeably mild shrinking of the palpebral fissure, which usually happens in squint, and sometimes the parents complain post-op that the eye looks, it's slightly smaller. So you need to educate them before surgery itself, what will be the appearance before you do the surgery. And this is a bimedial recession that we have done. We have recessed both the medial rectus muscles, and we see that the correction is also good. So this is a eye where this is a large angle squint, where we have 1 month post-op, child is presenting. There is a residual squint. So we have done only in one eye. You see the distance between the limbus and the canthus. So you see that the distance has improved well, but still there is some squint. You see that there is some amount of esotropia. So after 6 months, we have to do the other eye to get a good proper correction. So with that, this is an adult case also. Adult case also, we give cosmetic correction, and the results are good with the recess resect procedure. So with that, we'll come to our next important topic, which is exotropia. So exotropia, most common which we see is intermittent exotropia and then sensory exotropia. So we'll deal mainly with intermittent exotropia. So intermittent exotropia, we have both non-surgical and surgical management. So the non-surgical part, we have glasses, high minus glasses, occlusion therapy, and orthoptic exercises. Surgical intervention depends upon the type of intermittent exotropia that we see, which will come to see. These are the types of intermittent exotropia. To put it very plainly, we have a basic type where the distance deviation and the near deviation are equal. In convergence weakness, there is less convergence, so the near deviation is more. In divergence excess, where the divergence is more, the distant deviation is more. So these are the three basic types. So glasses, we need to give full correction when they have any astigmatism or myopia. The problem comes only with hyperopia. hyperopia up to +2 diopter, we usually don't correct because the child will try to accommodate to see better clear vision and the eyes will come towards the center. But which is more than +2 diopter, we usually prescribe glasses. So the other important modality of treatment is increased minus lenses. Though it has been very famously talked about, actually the minus lenses help a very small subset of patients. So we'll see how these minus lenses work. So when there is image blur, these minus lenses will cause image blur. When you give the minus lenses, it causes image blur. So the patient tries to accommodate. So when they accommodate, automatically convergence happens. So the eyes comes closer and there is reduction in intermittent exotropia. So this is how the glasses work, minus lenses work. The indications are to be given in basic and divergence excess in young patients who don't really do much of reading. So as the children become old, when they are involved with more reading, this accommodation causes loss of strain to the patient. So it's not very helpful in giving it to children who are very active in reading. And it's only helpful for a very small exotropia, like 5 to 15 prisms of exotropia. So this is how the minus lenses are given and how it works. So the other important non-surgical treatment is occlusion. So it's a very controversial topic. So usually it is done in the dominant eye or alternate eye patching. So the mechanism of action is the patching disrupts the suppression, because whenever the patient suppresses, then the eye goes into XT. So when you do the patching and improve the suppression and prevent the suppression, the squint seems to improve. So it's usually indicated in very young children, like you say a 3-year-old or a 2-year-old child presents with intermittent exotropia. So you need to have some treatment. So the parents also expect you to give some treatment. So in those cases, you can tell about occlusion, alternate eye patching, or if there is a dominant eye, then you patch the dominant eye so that some part of improvement or control is maintained. The next treatment is for older children, you give orthoptic treatment, convergence insufficiency type IXTs, we give orthoptic treatment. Near point exercises like pencil push-ups, we give. So this is how the non-surgical part is managed. Coming to the surgical part, so basic type where the near and distant deviation are same, we go for a recess resect procedure. We recess the lateral rectus and resect the medial rectus. While in convergence insufficiency, where there is a problem, weakness of the medial rectus, we try to strengthen the medial rectus by resecting it on both sides. In divergence excess, where the lateral rectus seems to be acting more, we try to weaken it by trying to recess the lateral rectus. So now I will try to talk about a procedure called plication. So it is a type of muscle strengthening procedure. So you know that all the extraocular muscles have the ciliary blood vessels. So basically in plication, what we do, instead of cutting this muscle out, we try to take a bite on the sclera and try to pull the muscle and suture it so that it is folded on itself. So why at all we do plication? We'll come to it later. We'll see the procedure, how it is being done. So you take the suture on both sides of the insertion. Rather than cutting the insertion and trying to bring the muscle forward, we are trying to directly make a bite near the incision on both sides. So once the sutures are taken, the muscle is brought forward. You see, the muscle is brought forward, the insertion has come I mean, the muscle has come in this area. You see the redundant muscle, which is folding over it itself. And the other side is also tied tightly. And the muscle is brought forward. So the muscle, extra muscle which is there will be pushed inside so that it disappears behind the insertion. So usually there is not a bulge or anything like that which is obvious. So it's basically done to prevent cutting the muscle and thereby saving the blood supply, which is important in certain scenarios we'll discuss later. So these are the immediate post-op. So after a IXT, so child is looking straight, and you see that after 1 month post-op, the correction is really good. So here we have a large angle XT, and this is 3 months post-op. You see that there is a good correction. You see, even though it is not fully straight, there is some amount of XT is there. This is where our orthotic exercises will help. So after surgery, we try to give the orthotics exercises so that the outcomes become better over a period of time. So we do in adults also for cosmetic purpose or for asthenopia. So we have good outcomes with research procedure. So now the another important feature which is associated with this horizontal deviation is pattern deviation. So it is a variation in the horizontal deviation size or amount in the up and down gaze. Like for example, this is an esotropic patient with V esotropia. You see that the primary gaze, there is esotropia. It becomes more in down gaze. You see 45 prisms becomes 50 prisms. And when the child looks up, it becomes less. So this is a V esotropia. And exotropia, V pattern is the most common type of pattern we encounter in esotropia and exotropia. So here you have an exotropia, which is a deviated eye. So as the child looks down, the eye becomes, the exotropia becomes less, and when it looks up, the exotropia becomes more. So why at all we should correct these pattern deviations? So why should we bother about them? As you see here, even if you correct the primary squint, when the child starts reading, when looks down and starts reading, the esotropia will become more and the child will have suppression. So to prevent it. So here also you see that when the child looks up, the exotropia becomes more. So it leads to a cosmetic correction like a cosmetic problem. So for that, when you have an A exotropia, the exotropia becomes more in down gaze. So when the child reads, the exotropia becomes more. So basically for primary gaze and for reading, we need to correct the pattern deviations. So this is a exotropia child. So as you see, when the child looks down, the exotropia is almost normal. So as the child looks up, you see that the exotropia becomes more. And this is what we call it as a pattern deviation. The variation in the primary deviation with up gaze and down gaze is called as pattern deviation. So how will you measure the pattern deviation? So though it is very easily seen that you measure the up gaze deviation, you measure the down gaze deviation, how actually we do it? This slide video will let you know how we do it. So for measuring the up gaze, we make the patient chin down and then we place the prisms to measure the deviation. You see, this is how the up gaze measurement is done. The chin is pushed down, so automatically the eye goes up and we measure the deviation. For down gaze, we ask the patient to lift the chin up and we measure the deviation. So how will you tackle these pattern deviations? So if there is oblique overactions, we manage the obliques. So V pattern is mostly caused by the infraoblique and we weaken it, and A pattern is caused by the superoblique. There also we weaken the superoblique. So if there is no oblique overaction and still the patient has a pattern deviation, so when you recess and resect the muscle, this is how we transpose the muscle. So in case of medial rectus, it's always displaced towards the apex, and in case of lateral rectus, it's always displaced towards the open end. So this is how we practically do. So you have a patient with exotropia. On up gaze it is increasing, in down gaze it is decreasing. So it's a V pattern exotropia. So if it's V pattern, then lateral rectus we have to shift up as we have done here, and the medial rectus we have to shift towards the apex, which is down. So we have done here. So this is the original insertion of the lateral rectus. So after recessing it, we shift it towards the side. And medial rectus resection, this is the insertion. So we just shift it down along the insertion, one muscle width. So this is how the pattern deviations are tackled when there is no oblique overaction. And this shifting of the muscles, they don't cause any vertical deviations or they don't cause any torsions. So you can safely do it, even in children who are having good BSV or stereopsis. So now we'll come to how we tackle the obliques. So as you see, the infraoblique overaction is graded according to the action of the infraoblique. So you always compare the limbus, lower limbus. So it's slightly high. Here it is +2. So you draw a horizontal line towards the up. You will see that the limbus is slightly more, and here it is +3 and +4. So depending upon the overaction, the muscle placement is managed. So this I will explain to you later. So we'll just see how our oblique muscle is being removed and placed. So this is the lateral rectus, which is dissected out, and the oblique is 8 millimeter behind the lateral rectus, 8 to 10 millimeters. So here is the lateral infraoblique, which is getting attached. So we are trying to see where the whitish triangle is. There, it's there where you want to put the hook for hooking. So you see the whitish triangle, you put the hook, and both the obliques, infraoblique and the superoblique, are embedded in the tenons. It's not over the sclera. So you have to retrieve it from the tenons. So now we are introducing the second hook, and we are trying to get into the tenons and stretch it. And now the hooks are relieved, and then we stretch and cut the tenons to make the muscle free. So this is a artery clamp which we use to clamp the near the attachment of the inferior oblique. So this is the lateral rectus, this is the inferior border, this is where it is attached. So use the clamp to hold the muscle and then cut the muscle fully and secure it. So now we'll secure it with a vicryl suture, which is a 6-0 vicryl and a spatulated needle. So we'll put 2 or 3 sutures, bites, and then secure the muscle tightly. So now we have to hook the lateral rectus, because along the lateral rectus only we are going to place the muscle. So after preparing the muscle, now we are hooking the lateral rectus, inferior rectus. This is the inferior rectus. So we are going to place the muscle. This is the border of the inferior rectus, which is over the sclera, which is very clear. So there we are going to attach the oblique at the level of the insertion of the inferior rectus, sorry. So this is the inferior rectus muscle. This is the lateral border. So at the insertion, we are trying to secure the oblique. So now the insertion of the inferior oblique is also in line with the insertion of the inferior rectus. So once the muscle is properly secured, the hooks are removed. So this is how we have placed the muscle. So this is the inferior rectus insertion, and we have placed the just at the along the line of the insertion of the inferior rectus. So this is the maximum precision which we can do with the inferior oblique. So now I will explain to you at what levels we have to place. So this is the normal insertion of the inferior oblique near the border of the lateral rectus. So we have to bring it and place it near the inferior rectus and its lateral border. So this is the 4 millimeter mark. So 4 millimeter is done for 1 plus. So as you keep increasing the recession, the mark will keep increasing towards the insertion of the inferior rectus. So 2 plus will be 3 millimeter. So we'll place it here. So 3 plus will be 2 to 1 millimeter. We'll place it here. And at the IR insertion for a very +4 overaction. So sometimes we place it slightly 1 millimeter anterior to the inferior rectus insertion. We call it as inferior rectus anterior positioning. We'll come to it later why we do like that. But this is how the inferior oblique is being placed at different levels for different levels of overaction. But practically speaking, we don't actually keep the muscle at 4 millimeter or 3 millimeters. So either we keep the muscle at 1 millimeter or near the insertion, because over a period of time the oblique overaction will increase. So it's better to recess it maximally so that the overaction doesn't come after some time. So that's how we practically do. So now we'll come to the superior oblique, how we handle the superior oblique. Here we are going into the superior nasal quadrant. Superior nasal quadrant, I am sitting in front of the patient or in the lateral side, and I am trying to dissect in the superior nasal area. You see near in the tenon space, as I dissect, you will be able to see the band of the superior oblique. So it's like a silverish band. So I have removed the tenons. Now I am going to rehold the tenon and then lift it up. So this is the oblique muscle. So this is the oblique muscle tendon. So you see a silverish appearance here when compared to the rest of the tenon. So you put the hook, just like the oblique, we remove the muscle and then we put a second hook. So we call it as a posterior 2/3 tenotomy. So posterior part of the muscle we'll remove. So you see the silverish appearance of the tendon. So we are removing the tenons attached over it. And now we are going to split the posterior 2/3 and the anterior 1/3. So with the scissors itself, we make a small gap and then extend the gap full thickness. It's a very, very thin muscle, doesn't have much of muscle fibers. It can easily tear if you give too much of force. So we are being very careful, and then part of the muscle is being cut once we have divided it and removed. So this is how a superior oblique posterior tenotomy is done to collapse a pattern. So this is how the superior oblique muscle is. So we remove part of the posterior 2/3 of the muscle. So it becomes less, and so the action becomes less. So this is how the surgery works. So with that, we'll come to end of pattern deviations. So now we'll come talk about dissociated vertical deviations. So first we'll see what they are, and then we'll see how they are being tackled. So this is a very manifest DVD. So eye is already up, and then once we do the cover test, you see that the eye is coming down. So once you remove the cover, the eye slightly comes down. So you see, once you remove the cover, the eye comes down. So what you have to be noting is, apart from the movement, you have to note the other eye movement also. So in case of a hypertropia, if you do a cover test and the eye comes down, automatically the other eye should go up. So this doesn't happen here. You see that? You once again closely watch. Once we remove the cover, it comes down, but you keep looking at this eye, there is no movement. There is no movement at all. So this is definitely a DVD. So here, even though the exotropia is moving, it's not going from above below. So it's a DVD. So here also you will be able to see a DVD in the case of esotropia. So you close and you take off the cover. You see that the eye slowly comes down, but there is no movement in the other eye. The eye comes down, there is no movement in the other eye. So this is what we call as dissociated vertical deviations. It's very commonly seen in esotropias and exotropias. So now we'll go as to how we tackle it. So initially we were telling about this procedure, inferior oblique anterior positioning. So rather than keeping the inferior oblique at the insertion site, we slightly move it a bit more anteriorly, 1 millimeter anteriorly, thereby treating the DVD. So we can also do a very large superior rectus recession. So these two modalities of treatment will tackle the DVD. So initially we were talking about plication. So I hope you will remember. So in these cases, when you have exotropia with a very large angle, a very large DVD, then apart from tackling the medial and the lateral rectus, you have to do the inferior oblique and the superior rectus also. So if you do 4 muscles, then you will be tackling 3 recti muscles, the medial rectus, lateral rectus, and the superior rectus. So in those cases, to prevent anterior segment ischemia, we use plication to save the artery from being cut, so that we only deal with 2 rectus muscles and a oblique muscle. So that is where the plication comes into effect. So with things, most of the things are taken care of, ESO, EXO, and the associated DVD, pattern deviations, and oblique overactions. So now we'll talk about adjustable sutures, because we want to give a good outcome. So for good outcome in cases like very small angle squints or unpredictable squints, measurement is not accurately possible, especially in children. And when surgeon is in the learning phase, we use the adjustable sutures. So this is the last part of the talk. We'll go into the videos as to how we put an adjustable suture. So as you see here, we already secured the muscle. Now we are taking a bite in the insertion itself, a cross bite, and we hold the muscle and then cut one suture. So this will become an open end, and then we'll take a single knot and we'll keep the caliper and measure whatever amount of recession that you are going to do. And then we make a shoelace knot. We call it as a bow tie. And then we pull the muscle down. So this is as good as a recession. Only thing, we are not attaching the muscle to the sclera. So you'll be able to see that this type of suturing is used. Even this part of the sclera is very thin also, we use hangback sutures. In hangback sutures, rather than putting adjustable knot, we'll secure the knot here, so the muscle will hang behind, getting with the suture in place, and it will be placed behind. So when there is any problem with the sclera here, or if the muscle is very myopic, you don't want to take any bites, so which will cause any perforation, we do a hangback. So hangback is different in the sense, like, rather than making an adjustable knot, you just make 2 or 3 knots here and make it permanent. So once you have put the adjustable, how do you adjust? So this is a patient requiring no adjustment. So this loop, you make a small cut, remove one part of it, and then you tie the sutures and secure the knot. So a patient who doesn't need any adjustment, you just have to open it up under topical anesthesia, make a cut, and then finish it. What if you need increase the recession? You want to increase the recession, so you give a subtenon's injection here, so that patient is pain free. So you see, once the subtenon goes, you see the immediate dilatation of the pupil, whereby the anesthesia has come into effect. So now you hold the knot and pull it forward, because you want to first remove the bow tie. You have to loosen the bow tie first. So you want to increase it by 1 or 2 millimeter more. You make a single knot and try to measure it. So we are approximately increasing it by 2 millimeters. So we are increasing the recession. So we are measuring it, and then you make the knot permanent. So once you tighten the knot, you just pull the sutures and increase the recession, so that the effect will become more. So what if you have done a overcorrection? So you want to decrease the recession. So you pull the knot forward. So how much of recession you want to decrease, you use a clamp to hold it. Then you remove the bow tie. And then you just make it permanent. So that's how we manage a recession. So this is how adjustable sutures are being placed, how they are adjusted, so that the outcomes are be better, and lot of uncertainty which exists in children can be tackled without apprehension. So when do you perform the adjustment? Either you do it on the same day or the next day. Usually in adults, maybe if you do it in the morning, you can adjust the suture in the evening. But usually under general anesthesia, we do it in the next day. So we give a short GA and take up the case for surgery. So I think with this, we have covered esotropia, exotropia management, surgical and non-surgical, pattern deviations, how we tackle with and without the obliques, dissociated vertical deviations, and then the adjustable sutures. So I think we'll stop with that. And any questions, we'll be ready to take. So the first question is, what is your opinion about procedures like plication, tenotomy in comparison to the most commonly done recession and resection? Yes, both of them, they work well. So we have had quite a lot of experience with both plication and resection. Both of them work. In fact, some surgeons now prefer not to do resection. They always do plication, so that any resurgery or anything that they want to do, they can always undo it. So the second question is presence of lateral incompetency in IXT. So lateral incompetency is when you measure the XT in the side gaze, in the right gaze or the left gaze, there will be a variation. So that variation will be very, very minimal, and it is very, very rarely seen. So if there is a lateral incompetency, usually along the side where there is a less deviation, you do less. In the area where there is more deviation, you do more. So that's quite simple. A role of prisms in the management of squint. Actually, prisms are more commonly used in acquired squints. So we usually don't use much of prisms in congenital squints, especially ESO or EXO. So even in IXTs, before they used to do orthoptics exercises with base out prisms, but those are all only very anecdotal procedures. So we don't use prisms much now. What is that? So does the plication of lateral rectus give some amount of ballooning? No. Actually, the lateral rectus is a more thinner muscle. So actually it slides perfectly below the insertion, and you don't have any ballooning effect. And the next question is amount of recession and resection based on the deviation. That is always given in all books, so you can refer it. It's all standard procedures which vary depending upon surgeon's preference and practice. What is the minimum time within which we have to adjust the recession? So actually here we take at least a day. So you do the surgery and then we do the adjustment next day. But in Western situation where they do under general anesthesia, which is after the patient recovers from general anesthesia, maybe within 1 or 2 hours, they do the adjustment. Glue, the question is, can we use glue instead of suturing the conjunctiva? That is looks very tempting, but in common practice, what we see is in children, there is lot of tenons. So what happens is with the children rubbing and also moving the eye, there is very high chance that the conjunctiva will get reflected back. So we always prefer only suturing. So the question is, we are only conjunctiva, whether it should be resected or not. So we commonly do the resection. We don't do any, excessive resection and all. We do it according to the amount of resection that we have done on the muscle. So definitely we do resection. So it really helps, and we have not had any problem with resecting the conjunctiva. Correct pattern deviation. So the question is, when do you decide to operate on a partially accommodative esotropia? Yes, when you give the glasses and you see that the squint is more than 10 prisms of esotropia or it is causing any amblyopia. So we have to take both into consideration. Sometimes even if the squint is relatively big and the child doesn't have any esotropia, we don't operate immediately. So we usually wait and watch. But if it is more than 10 prisms and is causing amblyopia, then we operate on the residual squint in case of partial esotropia. The video. Okay. So AV pattern, how much deviation is significant is very basic question, which is always given in all primary textbooks. Any deviation more than 15 prism is important for V pattern, or anything more than 10 prisms is significant for A pattern. When should you expect to make phonics based incision? Phonics based incisions we usually do when the patient is very, very young. They don't want to have any, when they want to use any contact lenses or something like that, you don't want any scar in the limbal area, then we do phonics based incisions. It all depends upon the surgeon's preference. As you saw in those post-operative photos, whether you do phonics or limbal-based incision at 1 month or 3 month post-op, you usually don't have much of scarring. So sometimes it's very difficult even to notice which eye we have operated. So there is not much of scarring as it is being told in the literature regarding limbal incisions. Do you in favor of overcorrecting exotropia is the next question. Yes, we usually plan for overcorrection, and that is where we use the adjustable sutures very commonly. So usually we prefer an overcorrection of around 10 prisms. So anything more than that, especially in children, it's dangerous because they will start having diplopia, they will start suppressing the eye, they will start accommodating, and it will cause more esotropia. So in those cases, sometimes we end up correcting more in children. We give them hyperopic correction so that the accommodation is relaxed, and we'll wait for 1 month or so and see how the overcorrection works. And if it is persistent and the child is having a problem and you feel that the child is going for suppression, then we'll have to reduce the correction. So it's been a good session with a lot of questions. I think we'll close it now. Thank you.